Bonjour, merci. I am going to start with something that my mom said I had to do or she would disown me, which is say something in French. So I didn't trust my own French, which is very rusty, so she wrote out some phrases for me. So just merci de votre invitation. C'est un plaisir de me trouver parmi vous aujourd'hui. I can remain in the family too, that's important. But really do want to thank you for having me, and it's nice to be in a community of people who are interested in these topics and to be able to share ideas and see where things need to be done and how we can get them done. This work is really about what is happening in society, what are some major socioeconomic trends in society, and what are they doing to our health, and how do we sort of study and find evidence of what's happening. And I want to start with two sort of ideas and a background that animates most of my work. It sort of informs how I think about these things. And the first is a sort of biological model. And this model essentially informs us how it is that the social world, how it is that our socioeconomic position biologically embeds effectively. And it's done by a neuroendocrinologist, Bruce McEwen, who does really nice work. And the idea is that our brains and bodies perceive stress from the environment. So we perceive stress at work, at home, and so on. We perceive stress from major life events, from unfortunately things like trauma and abuse, but also daily chronic low-grade stressors. And a lot of the literature suggests that the most important thing for health, especially for the major causes of health, are ironically these low-grade chronic stressors. It's not the big things that really influence our health. It's the fact that we're under stress repeatedly, all day, every day, in small ways, but we really don't have a chance to recover from that. And the idea is that that stress is perceived by the brain, and then the brain does a bunch of different things with it. It may lead you to different behavioral responses to cope with the stress. So everything from smoking, drinking, other substance use, to whether or not we eat well, whether or not we exercise, are very sort of constrained and conditioned by what kind of stress we're experiencing. So we often in public health talk about health behaviors as if they are something that we voluntarily choose to do or not. And these kinds of models give us a biological basis for understanding why some people are more likely to be able to engage in healthy behaviors than others. Our brain also physiologically manifests this stress in things like blood pressure and other sort of stress hormone responses. And so it's clear from this that there are multiple reasons that our social world literally embeds in us. The second kind of idea that I think about a lot is that while it's true that the social world embeds in us, the reason that we have systematic differences in how that transpires is because stress itself is different across our socioeconomic groups in society. So most stress is concentrated in lower income groups, in other groups that are more disadvantaged, because they are more likely to receive these everyday stressors, worrying about money, being discriminated against, having a job that is unpredictable, and so on and so forth, are causes of everyday chronic stress, and they tend to be more concentrated in lower socioeconomic status groups and other groups that experience societal disadvantage. And if you trace why that happens, inevitably you get to large societal forces like social policies, which are the source of how this stress and how resources are distributed to people in various positions. So it doesn't have to be that the highest stress burden and economic insecurity and so on fall on the disadvantaged. We've actually created a society in which that occurs, and we've created it through the kinds of policies we've enacted. And so we know this from a very broad range of literatures, from economics, political science, sociology, and so forth. And in public health, we've realized that that societal organization has health consequences. So this is kind of a general backdrop for me of how to understand public health problems, where to start when we see public health problems arising. So one major public health problem that's happening now, that's being recognized increasingly, is this rise in the extent of socioeconomic health inequalities. We've known about health inequalities for decades and hundreds of years and so on. It's not a new thing to say that there are socioeconomic inequalities in health. What we're recognizing now is that they're getting worse. And that is despite the fact that they've been recognized for so long, and despite the fact that there are very good actors on the ground trying to do something about this. This picture is from a report done by Toronto Public Health, which is the public health agency in that city. And in 2005, they recognized that there were income differences in health, and they wanted to do something about it. And so they set out to create programs and services, particularly for lower income people, things like smoking cessation programs, breastfeeding programs, and so on, to tackle this issue. So 10 years later, they went back and measured health inequalities again after they had done all this work to address them. And they found things had gotten worse. Over the time that they had enacted these problems, 21 of the 34 health outcomes for which they did analyses had gotten worse, meaning the gap in health between the rich and the poor was wider than when they had started. And for another 16 indicators, there was just no change at all. And this is being recognized all over the place in the rich countries. So there's Canadian data on it. So Canadian health inequalities seem to be rising. This is US data. On the left-hand side is life expectancy for men, and on the right-hand side is life expectancy for women. And the top yellow line is the increase in life expectancy for the richest Americans. The blue line at the bottom is the life expectancy change for the poorest Americans, the poorest quartile. And you can see that over time, the steepness of the yellow line is much greater than the steepness of the blue line, meaning that there's a widening of life expectancy inequalities. So everyone's doing better, but the richest group is doing much better. And so the question is, why is this happening? Again, UK, same story, evidence showing that these inequalities not only exist, but they're getting worse. And if you think back to the original two slides that say this is happening because biologically we are embedding a societal context, and that context is largely about things like policies. And you say to yourself, well, what's been happening over the time that health inequalities have been rising? What's been happening to policy, for example? Well, one major change in policy has been what many social scientists refer to as retrenchment of the welfare state, meaning that social policies during this period have gotten stingier, less generous, and not only are they less generous because the amount of the benefit people get from things like income assistance policies is smaller, these policies have also reduced the number of people who are even eligible to get benefits. So we wanted to know, can we pick out a policy change that occurred over this time and see what its health effects have been? So we picked what they called in the US welfare reform in the mid-1990s. This was enacted by the Clinton government, and incidentally, one additional finding has been that it is the centrist governments that have been implementing these rather harmful policies. So these are not all far-right governments. It's often what we consider to be centrist governments that have been doing this. And so under the Clinton administration, they changed their social assistance or welfare program. And they, again, implemented cutbacks to how much money you would receive. They decided that if you wanted to receive benefits, you had to be working. So there was much more stringent, they were much more stringent in terms of job employment requirements to receive income at a time where it was very difficult to find jobs. And they also restricted eligibility criteria. So this was largely a program that you could receive temporarily and only if you had young children and so on and so forth. And so we wanted to know what happened when the US went from a, albeit not great, but more generous social assistance program, went through this welfare reform and landed on a less generous program. And we picked the US in large part because the US makes its data available. And so it's much easier to do this work on the US. And if you look at the social assistance literature or the social policy literature or the social policy and health literature, much of it is in the US, and I think there are several reasons for that. I don't think there are many people doing this kind of work in Canada compared to what you see in the US, even if you account for sort of population size differences. But I do think a big factor driving all of this is that the data is readily available. So we had the data, but these are still very difficult questions to answer. The idea of figuring out how much did a specific policy change health or health inequalities is extremely challenging because it's difficult to isolate the effects of a policy from everything else that's happening. So we have techniques to do that, but it's often hard to implement those in any real way. In this situation, we thought we might be getting there. Effectively, what you want when you're studying something like this is to know who the group is that's exposed to policy. Sorry, the blinker thing, the laser isn't working. But you want to know who is in the group before the policy change occurred, who is going to be exposed to the policy change. So this dashed line is the point at which welfare reform occurred in the US. So you want to be able to track the change in their health from before they experienced the policy change to after the policy change. But that's not enough, because whatever changed for them may be a result of things other than that policy. Other things may have happened. There may be a change in unemployment rates. There may be a change in health insurance. There may be all sorts of things. There may be a recession. You know, there are so many things that could happen that at the same time that cloud your ability to say whether your results are really about the welfare reform, the change in the policy, meaning it makes it difficult to say that the observed change in health is really about what you're saying it's about, which is the policy. So the big challenge is to find a control group, a group that did not experience welfare reform, but experienced everything else that may have changed during that time, so that they are comparable enough to the group that experienced welfare reform that you can say, well, that group says to us, here's what happened to everyone else. And so any difference between those two groups can be attributed to the policy change. So one group experienced policy change, the other didn't, but otherwise they're very similar. In the Canadian context, I was telling Judith that people often like to compare Ontario to Quebec to study policy. And the idea is that, again, you have a treatment group, a group that underwent some policy change, and a control group, a group that is similar to the group that underwent the policy change, except that it didn't undergo the change. But as I'm sure you will proudly say, there are many things that make Quebec different than Ontario other than a simple policy change. So the question is, can you really use these provinces as controls, and therefore can you really isolate the effect of a policy by comparing them? And that's sort of a broader discussion. So we did this study by comparing who we thought were the most likely to undergo this policy change, who were the most likely recipients of welfare, who then would experience change in the welfare system, and that in the US is low-income single moms. And so then the question for us was, who do we compare them to? Do we compare them to low-income moms who are married with kids? Is it low-income moms without kids? And so you start to see this problem of who do you compare your group who is experiencing policy change to in order to isolate the effect of the policy. And I won't bore you now, but we used a couple of techniques to do that. In the end, we observed how health had changed for low-income single moms in the US from before to after social welfare change. And we did so across a range of outcomes. At the top is safe drinking, then whether or not you smoked, how many days of good mental health you had, how much medical access you had, whether you were able to afford a doctor, whether you had a pap screen, and whether you had a mammogram. And if you move to the left of the graph, health is getting worse. There's a greater percentage of people after welfare reform experiencing bad outcomes. And you can see from the blue dots, which is one technique we used, and the orange dots, which is arguably a better technique, that almost uniformly you had worsening of health for low-income single moms after welfare reform occurred. So this is a sort of pinpoint, a data point to help us understand how these health inequalities are widening. One reason is that we're implementing social policies that are not benefiting people who have disadvantage. We're actually making things harder for them. So then we decided, let's just do it. Let's try to do this in Canada. Let's try to do this in a more comprehensive way, because if you look at the literature, again, very little that informs the Canadian context. So we looked at the impact of social assistance policies, what the US calls welfare, on health in Canada, and we redid the US, and we also looked at the UK. And we also looked at Ontario. The Ontario government wanted to see our data for the province. So overall, this is what we found. We found that receiving social assistance is associated with poorer health, at best, or no different health, even when you use many of the best available methods for controlling for other explanations. So even when you have a pretty good control group in place, social assistance doesn't seem to be helping. The one issue is we weren't able to use quite as good a technique as we did for the US data, because the data just wasn't available for Canada. But this was actually quite surprising to us, and I'll show you why. So we did this study in 3 ways. The first is we did a systematic literature review to see what it was that people had found in the literature on the relationship between social assistance and health. And then we did our own studies. The first was to look at the population of social assistance recipients and compare them to matched non-recipients. Again, the matching is so that we can isolate the effect of social assistance. And then we said, what if instead of comparing groups, we follow individuals over time? And we see what happens on average to individuals, how their health changes over time as they move in and out of social assistance. So the first study was again the literature review. And here's what we found. We found that most studies suggest that social assistance recipients have worse health than comparable groups. So again, if you go back to the framework, we think that social policies should be helping people at the margin. So we're not saying here that social assistance recipients have worse health than the general public. That's not a surprise. But that they would have worse health than comparable people who aren't receiving social assistance was a little bit of a surprise. And what we thought might be happening as we looked at the literature is that the groups actually weren't as comparable as the studies were suggesting. And we also found, again, that they weren't using the methods that you could use to analyze this that would give you a better estimate of the social policy effect, because it was unclear if the groups actually were that comparable. And just to repeat myself, very few studies from Canada. So then we said, okay, well, let's do our own analyses. And the first one was to compare groups, compare social assistance recipients to non-recipients. And we did this again for Ontario, we did it for Canada, we did it for the UK, and we did it for the US. So I'll give you a little sense of how we did it in Canada. In Canada, we used the Canadian Community Health Survey. And we took from the survey all people who reported being social assistance recipients. First we divided people into the groups that we thought were the most likely to be on social assistance, but may have some differences themselves. So that's people who are low income and unemployed versus low income and employed. So we thought because employment might confound the association, we're going to study these groups separately. And then we said, if you are low income and unemployed, how many of you are social assistance recipients? And then we found matched non-recipients for them in the sample. So it's like an active effort to construct a sample that consists of people who are exposed and who are matched and unexposed, as opposed to just everyone in the sample. And we did the same for the low-income employed, social assistance recipients and matched non-recipients. And then you figure out what are the health differences between recipients and matched non-recipients, with the idea that this tells you something about the effect of social assistance because people are otherwise similar. And here's what we found. The top left-hand graph is poor self-rated health. Bottom is current smoker. The top right-hand is chronic conditions, and the bottom is obesity. And the bars represent the percentage difference in poor health, like worse health on each indicator for social assistance recipients compared to matched non-recipients. So you can see in every case, the bar is above 0, which indicates there are more social assistance recipients that are in worse health, who are more likely to report poor self-rated health, more likely to have chronic conditions, more likely to be current smokers, and more likely to be obese. So the percentage of social assistance recipients with those conditions is higher where it's significant and no different where it's not significant than matched non-recipients. Again, you expect that if you are in a low-income group, you would have some benefit from having social assistance, and that's not what we observed. So these are the results for the employed subsample, and almost the same thing for the unemployed, with more cases of no different health status, meaning social assistance recipients who were unemployed weren't doing worse, but they certainly weren't doing better. They were basically no different than non-recipient, low-income, unemployed people. Then we said, okay, let's follow individuals over time. We've now compared groups and seen how groups are different. What happens when we see a particular individual come in and out of social assistance? On average, how does that change? So these analyses I just showed you were just a cross-section. How does one group compare to another? Now we're saying how do things change over time? And again, we did this for Ontario, Canada, the UK, and the US. And this is a little bit of how the study design works. So we used the Survey of Labor and Income Dynamics from Canada, and we tracked individuals over time. We looked at whether they were labor market active, whether they were in the lowest income decile, and whether they experienced a change in health status over time. And that's how you were included into the sample, is if you met those criteria. So again, we're trying to narrow down to the people who are the most likely to be social assistance recipients or matched non-recipients effectively, in order to make sure we're not getting a lot of confounding by other characteristics. And then we follow them over time and track their social assistance receipt, their labor market status, and their health status. And these are not percentages, but odds ratios. So this is the average odds of experiencing poor self-rated health by your, this is by country, so Ontario, Canada, US, and the UK. So the average odds of experiencing poor health if you are a social assistance recipient compared to a non-recipient, controlling for many, many characteristics. This is a fixed effects model, which is useful because it controls for a lot of things that we can't even measure in surveys that may affect results of how people do over time, your personality characteristics, and so on and so forth. The reason it does that is because it uses the individual as their own control over time. And so again, we found that social assistance recipients were either more likely or no different than, if you were in social assistance compared to not, you were more likely than, or no different to report having poor health status. So our idea that the literature, which already reflected these findings, that social assistance is really not helping people's health, our idea that that was because the methods weren't good enough did not come true. We found very much the same thing despite using many of the best methods we have available. So the three components of the study yielded really consistent results. Despite the fact that we think social policies should be helping health, they should be helping the health of the poor, they're not. And we think there are a few reasons for this. The first is that because of this welfare state retrenchment, because of these welfare reforms, which Canada also underwent in the mid-1990s, we have such a stingy system that the benefits are simply inadequate to show any discernible difference in health. It's just not enough money to make a big difference. The other possible reason for our results is that we do have more work requirements now than we used to. They're not as strict as the US, but they are there. And that given the labor market and the labor market conditions that low-income people experience, the effect of forcing people into bad jobs and a bad labor market is outpacing any good effects that you might get by giving them income assistance. So that's another possibility. The third is that you may actually be measuring what we call a selection bias, which is that sicker people select into social assistance. So we controlled for a lot of that. We controlled for a lot of health conditions and so on in our matching processes. But there is an incentive, if you are poor, to go onto social assistance. If you are poor and sick, to go onto social assistance, because you cannot get things like prescription benefits and dental benefits without being on social assistance. And so what we may be seeing is this selection bias as a result of how the policies are designed, how benefits are distributed. So if we lived in a world where we had universal prescription benefits, we may see less of this selection bias, and it may have meant that our results would have been different. And then finally, of course, the study is far from perfect, and there may be other variables that we haven't accounted for that may be influencing our results. Our sense is that what would be nice to see is a study that could capture a policy that provided more income supplementation than most policies in most countries like Canada, and a policy that removed work conditionalities, and a policy that again reduced this selection bias effect, that gave people dental coverage, prescription coverage, and so on, just as a matter of citizenship. And the sad thing is, it's very difficult to study this because it doesn't exist. So I often tell my students, the way that I am teaching you about social policy effects is to teach you what happens when social policies get worse. Because we don't have examples of when they get better, because we are living in an era where we are making things worse. And that's the broader context here. So I studied, and my team studied social assistance policy. It's a very important policy, but there are a broad set of societal conditions that have gotten worse for the disadvantaged. And our sense, our hypothesis anyways, is that health inequalities widening are really a function of a suite of changes to society that are making things much worse for the poor and infinitely better for the very rich. And you can see what's happened to income inequality in countries like the US and Canada. If you look at the Gini index of income inequality, and a higher Gini means a higher degree of income inequality. If you look at the Ginis for the US and Canada before taxes and transfers are applied, you can see that they actually have fairly similar inequality. So this is just based on what people earn before there's any kind of redistribution through taxes and so on and social assistance. And if you look at post-tax transfer income inequality, you can see the difference for Canada is much greater than the difference for the US, meaning Canada is much more likely than the US to use taxes and transfers to redistribute income to the poor. But we're getting worse and worse at it. So what used to be something that distinguished us now I think is better framed as we're just worse to a different degree. And I think this is kind of the one of, if not the most, one of the most pressing public health problems that we have to contend with, this idea that we're setting up a society in which it should be no surprise to any of us that health inequalities are widening. And I'll leave it at that. Thank you.
Merci beaucoup, Arjumand.
Thank you.
Est-ce qu'il y a des questions dans la salle?
Thank you for your presentation. I was surprised at your slides showing that the US did better than Canada.
Sorry, which one?
Well, several of them when you were comparing groups.
Oh, yes, yeah.
And it goes against everything we believe in.
Yes,
Canada,
yeah.
Right? We're supposed to be so much better than the Americans, right?
Yes. It's a good point. So there's a few possible explanations. One is it's actually true that we're not better. The second possibility is that the people in the social assistance recipient group in the US are much worse off than they are in Canada because the eligibility criteria are so much stricter in the US. So many people who are in the social assistance group in Canada are actually in the, those types of people are in the non-recipient group in the US. And so it's tilting away from making social assistance look bad only because you can't even get into the social assistance group. So we think that eligibility criteria might be a big part of this. But it's a good point. It is possible that we just are not as good as we think we are. We're not sure.
I'm wondering, could a lot of this be explained by the fact that our social, our redistributive systems are picking up the right people to give more resources to? So they're finding out the most vulnerable, then we're giving them more. And for some reason, we cannot identify the factors that make them more vulnerable. And when we try to compare them to others, well, we find that they're worse off because they are. Because somehow the rules and regulations, even though we keep pushing the line further down into the vulnerability space, we still are able to find the ones that are most vulnerable and most in need.
Can you give me an example?
For instance, if we say that in order to be entitled to receive social benefits, you have to have a minimum income of less and have 3 chronic diseases, and maybe that's also associated with also having worse health conditions in other fields, being more likely to be smoking, drinking, and having other kinds of behaviors. Maybe the criteria that make the social benefit systems are intrinsically selecting more vulnerable groups because those who are not entitled to, who do not meet those criteria, well, they're better off by definition.
Yeah, so I think some of this may be the selection process you're thinking of. So while we don't explicitly use chronic conditions, for example, as a way to determine who should get assistance, I think it may be that there are sicker people who are selecting into social assistance programs. I think the answer to whether the other group is better off is when our relative judgments should also introduce some absolute judgments, which is to say neither group is doing well, right? So these are studies that try to isolate the effect of a policy, but they don't suggest that somehow either group is doing well nor well compared to other income groups. So this is really a question of what we feel is fair in society, right? So if we accept that it is an injustice, that the reasons low-income people have worse health are because they are subject to negative societal forces, then I think both groups are groups that we should care about because they're both in that most disadvantaged category. But certainly from a perspective of studying policy, I think you're quite right that sicker people may be selecting into policy. I mean, I think the idea that we push further and further is less rooted in the idea that we're trying to identify the people who will benefit the most from the from the benefit, from the sort of from the social assistance, and is more an orientation to figuring out how we can be increasingly limiting in who receives government benefits. I mean, this period during which social policies have changed is a period during which even ideologically there is a big shift in what people think the government should be doing for people who are disadvantaged. And I think our policies reflect that.
Do I understand that we have no studies showing that by giving more money to people, we improve their health?
So we have some small context specific, so like there's minimum wage. When you increase minimum wage, there are studies that suggest that you improve health by increasing minimum wage. There are studies, for example, in the US context, there are studies where they've shown in indigenous groups, those that receive transfers have done better in many respects. So it's not that there's no direct evidence that more money isn't better, which is why we don't think the way to interpret our results is that it's bad to give money to poor people. We don't think that is a valid interpretation, precisely because these other studies exist, precisely because we know about socioeconomic inequalities and that the rich have better health. But there isn't a lot of work, if really any work, about social assistance. And that's because the time period during which we can study this is a time period during which policies have gotten worse. And so we're having a hard time making a case for more generous social assistance directly because we simply don't have examples of better social assistance.
What about the effect of the number of years spent on welfare before getting the cut or the improvement? If you look at the time on, because the health is could be considered a result of something and not just an immediate impact of more money.
I think you're absolutely right. We did not look at that because we didn't have the sample size to be able to do it. We were sort of surprised we had the sample size to do what we did, frankly. But I think what you're saying is quite true. I think the longer you're on welfare, my sense is that things are often worse. I think some US data has shown this. So partly we need to know, A, what happens when you're on it long term, B, what happens when you're on and off. And in the current labor market circumstances, that becomes a big issue as well because jobs are precarious. People don't have full-time jobs with benefits and so on. They tend to have contract work. It tends to come and go. And so you find this kind of on and off phenomenon. And I think you're right, it would be important to know.
The other question concerns the outcome that you looked at. Some are access measure, other are not really income status. I mean, mammography is a process, access to physician, access to other services is also a process measure. And that could be conditioned by the amount of money you have. It doesn't mean you're sicker. Am I right?
That's right. So in the US, we looked at that because welfare reform also had implications for health insurance. So the idea is that some of this was about whether or not you got access to care. So whether your health changed, but also whether your access to health care changed.
And if we could select outcome measure, which are, it's a result or a measure of bad health. I don't see in your outcome many of those measures.
Could you give me an example?
Let's look at what you have here.
This is the US one,
yes,
and then
the safe drinking that's I guess smoking would be, well, it's not even, of course you're going to get sick if you keep on smoking, but maybe days good of good mental health could be the only, I would argue, measure of health status that you have.
I'm not following you exactly. So the not smoking, you're thinking?
Well, the health outcome.
In terms of health outcomes.
Yeah.
These are not health outcomes.
Oh, I see. So we just did a range of things that are either outcomes or risk factors.
Yeah, these are risk factors.
Yeah.
And of course, they will give you some bad outcomes one day, but so if you say that giving more money doesn't have any impact on health status, it's probably right in the long term. But what you're showing is that it's not that. You're showing that people who receive less money have bad risk factor.
No, not quite, because this was a change model. This is how much they have. Not only have bad risk factors, their risk factors got worse. And then in the Canadian, when we redid this in the second study, we had obesity and chronic conditions that we looked at. So we looked at health status as well.
What about the stigma of being on social assistance itself? And then you'd compare sort of general universal programs versus selected programs.
That's a great question. I was skeptical that stigma was anything so large that it could account for our results, but I think I was wrong. We went to the literature, and the literature suggests stigma has major effects both once you go on, but it also helps to determine who goes on and off. And so this also may be a part of our selection bias, meaning the most desperate people who can't pay attention to stigma because they have kids who are sick, who need the medical care or something like that, are in our social assistance group. Whereas the people who are more robust for some reason don't want to deal with the stigma and are off social assistance. It's a great point.
Hi, my name is Ahmed. I'm also a resident here. I just had a question near the end. You were saying that policies are generally getting worse. There was for a brief time the pilot basic income project in Ontario. I was just wondering if there's any data from that or if you guys are analyzing it.
Yeah, I'm not allowed to say too much about it. I'm part of that team, but I think a lot of that information is confidential. I will say I don't think there is data available from it because it was ended quite early. But let me tell you my thoughts on what I think might have happened. So it's possible that basic income would have resulted in better health than basic social assistance as we know it, because you did get more benefits and you didn't have the work requirements and so on that you did from social assistance. So it was an improvement. My concern is I'm not sure how much of an improvement it really was. And one of my doctoral students, Faraz Vahid Shahidi, who does work on unemployment insurance and health, he pointed out very early on that the basic income amount that people were to receive still did not match what they received on social assistance before we cut social assistance in the mid-90s. So imagine that you're receiving less, adjusted for inflation, than you received in the mid-90s, and think of how much more we have to purchase to live a decent life. Think of how much rents have increased. Think of how much the cost of food has increased. So I'm not that optimistic that it would have been that profound a change in any case. And I guess what I'm sort of trying to embed there is my gut is that we need to do some pretty radical stuff in order to see any major change. I don't think we can make little changes here and little changes there and expect health inequalities are going to turn around. I think things are just too far gone for that.
Coming back to your first or second slide on stress and the impact on stress on the health outcomes, could we think that the design of the welfare programs may add stress in many requirements and fear of being cut and things like that? Could it be a possible explanation for the bad performance of the program?
Absolutely. I mean, I think, as you said, sort of the fear that comes and the stigma, for that matter, that comes with being on social assistance is a chronic daily stressor in that group. So I think it could absolutely contribute. And I think what compounds it is that you're asking people to work or to be searching for work and be engaging in the labor market when the labor market is terrible in this group. And so my sense, speaking of bold changes, is that this is both about what we do to social assistance policy and what we do to the labor market particularly for low-income workers. So that combination of being exposed to both bad policy and a bad labor market, I think, is extraordinarily stressful.
S'il n'y a pas d'autres questions, merci beaucoup. Merci Arjumand.
Merci. Thank you. Merci beaucoup.